Hello all. Today we'll be briefly discussing the spectrum of oncological emergency that is presenting to our emergency room. So over to the introduction. So I'll be briefly dealing with the common oncological emergency that we see in our emergency room, and I'll be discussing in detail about febrile neutropenia or neutropenic fever, also tumor lysis syndrome. So these are the two important emergencies that present very frequently to our ED. So I'll be briefly covering what is the diagnostic criteria, how to go about it when you suspect a patient with neutropenic fever and all those things, and overview of ER management. So what you need to do when such a patient with suspected neutropenic sepsis or tumor lysis syndrome come to the ED, what are your treatment plan, that will be the discussion, and finally the conclusion. So coming to the common oncological emergency, see, I have listed a large list of commonly occurring oncological emergency that presents to our ED. So these oncological emergencies can be either due to a metabolic issue or due to a structural issue, or mostly an hematological malignancy related issue, or as a part of treatment that you are initiated to the patient. So you think of a neutropenic sepsis or a neutropenic fever, that is patient come to you. So usually it will be the post chemotherapy. The patient will be coming to the ED with the history of fever, sore throat and all those things. So the oncologist will be advising them to frequently check the total count. If there is any drop in the count, they will immediately ask them to report to the ED. That is how usually they report to us, and many of them will have associated fever also. So we'll go through the diagnostic criteria. So the most common one what we see is the neutropenic fever followed by tumor lysis syndrome, one of the commonest oncological emergency that we can see. But many a times you need to specifically look the diagnostic criteria for tumor lysis syndrome, otherwise you will miss. You will be just treating the electrolyte disturbances. When you put all the puzzles together, it will come as tumor lysis syndrome. So you should have a high index of suspicion of these things. And hypercalcemia of malignancy. So the patient might be presenting just to the ED with some generalized weakness and all those things. When we go through, they are evaluating them, you will see hypercalcemia. So one of the most common reason for the ED presentation for the oncological emergency can be again hypercalcemia of malignancy. Then it can be a hyperviscosity syndrome. Malignant proliferation, they usually very frequently come secondary to metastasis or due to a primary lung disorder. These patients come to us with worsening breathlessness. So that is one of the other common presentation that we see in our ED. And cholangitis, biliary carcinoma, very frequently they would have gotten in palliative stenting or in biliary drainage they would have done. But right now they would have come with abdominal pain, fever. So cholangitis is one of the other presentation that we frequently see in our ED. And they can come with certain paraneoplastic syndrome. So just like SADH, they are presenting with hyponatremia. So when you evaluate hyponatremia, you finally found out that it is an SADH, and most commonly the SADH, as you all know, it is due to a lung malignancy. So paraneoplastic syndrome presentation is the other part that we commonly see. And anemia and pancytopenia. A lot of patients being referred here, they have found out to have anemia and pancytopenia. So when we evaluate them in detail, finally turn out to be one of the hematological malignancy. So that is the other common presentation that we see. So they can come in emergency, as I told, they can even come with severe anemia and associated with pancytopenia, severe neutropenia, again with sepsis. So GI bleeds, upper GI bleed, both lower GI bleed, they can have the oncology patients, they can have a primary presentation or maybe a secondary. They are getting the treatment for the same, they can present with a GI bleed. And now these days what we frequently seen is that acute LVF, left ventricular failure, maybe secondary to any of the chemotherapeutic agents that you have used, or maybe that is precipitating their underlying CAD. Any small arrhythmias, maybe a fever associated with the ongoing treatment, they are developing a small sepsis, and on top of that they are developing arrhythmia and they are going to acute LVF. And it can be directly related to the drug that has been used for the chemotherapy, or it can be secondarily attributed to various other factors. Then rarely we see the drug reactions following this oncological drugs that been instituted. They can come with the features of anaphylaxis similar to that of anaphylaxis, but that presentation is not very common. And again, as you all aware of the superior vena cava syndrome and venous embolism. So as malignancy patient itself is a high risk potential to develop this venous embolism. So they also can present with one of this DVT or any of this venous embolism. So this is in general what is the spectrum of diseases that we see in our ED. So I have maybe I would have missed a couple of them commonly presenting in other center, but these are the things that we commonly see in our emergency department. Now coming to the next thing, this is again a pictorial representation of what we have said. So maybe they have primarily presenting to our ED, they don't have diagnosed have a cancer. Maybe they will be coming with, as I told, with an anemia, and later on we are diagnosing an acute chronic myeloid or an acute myeloid leukemia. So these are they may present in tumor lysis syndrome, they may present with SIDH, paraneoplastic syndrome presentation, and structural complication from cancer. So that is the other presentation, and they can have the complication of cytotoxic or systemic therapies. Maybe they have already started on chemotherapeutic agents and they are coming with any of these complications, and complications of sometimes the targeted therapies, and finally we have a group of patients who are under palliative care presenting with worsening of their disease. So the underlying disease they would have worsened and they are coming to our ED. So this is the in total what are the common oncological emergency. As I told, it can be part of the cancer itself or it can be the part of the treatment that has been provided to them. So these are the two groups of patients that we commonly see in our ED, or maybe in any ED this will be the spectrum. So coming to the most common one what we see, as I told, is the neutropenic fever. As you all aware, it is the most well-known oncological emergency, and up to 80% patients receiving chemotherapy for hematological malignancy will develop neutropenic fever at least once during the course of therapy. So that is the incidence been as per the evidences that you see, 80% of the patients receiving chemotherapy for hematological malignancy will develop neutropenic fever at least once during the course of therapy, and 1 to 3 patients with solid tumor are reported to develop neutropenic fever at a rate of 10 to 50% during the course of chemotherapy. See the spectrum again, it is very huge. 10 to 50% of the patient can develop neutropenic fever, and the absolute neutrophil nadir is often 7 to 10 days after the conclusion of chemotherapy. So their presentation may not be initially just soon after chemotherapy, maybe they will come later, maybe after 5 to 10 days after the treatment that has been initiated. So what is neutropenic fever? It is basically defined as a single oral or an axillary temperature of more than 38.3 degrees Celsius or 101 degree Fahrenheit, or a temperature of more than 38 degrees Celsius or 100.4 sustained over 60 minutes in a patient with an absolute neutrophil count less than 5000 plus microliter. So that is pretty simple, straightforward. So ANC less than 50 with fever, you can call it as an neutropenic fever. So above 38 degrees Celsius or 38.3 in a single reading, or you have a sustained fever for more than 60 minutes above 38 degrees Celsius with absolute neutrophil count less than 5000 microliter, you can call it as a neutropenic sepsis, neutropenic fever. Neutropenia can be characterized as mild, moderate, severe or profound. So this is the classification. So absolute neutrophil 1000 to 1500 we can call it as mild neutropenia. Moderate neutropenia ranges from 500 to 999, that is below 1000, then 100 to 499, then profound neutropenia less than 100. That is a classification. So as the neutrophil counts decreases, the severity also increases. Only 20 to 35% of the episode of NF are actually due to clinical documented infection. So when you look the blood culture, whatever be the source of infection you are trying to find out, only 20 to 35% of the patient only you will be able to get a pathogen. You will be able to isolate a pathogen. Rest of the time you will not be able to isolate a pathogen. So this is again clinical significance. So more than 1500 is normal, 1000 to 1500 less chance of infection, less than 500 to 1000 possibility of infection starts developing, less than 500 very high chance of infection, few clinical signs of infection may be present. So you always should have a high index of suspicion when these patients present to you, and they definitely need treatment with IV antibiotics. Less than 200, the inflammatory process will be totally absent, so there might not be any of this inflammatory process that you will be able to see, and it is very, very significant and profound neutropenia. So less than 200, absolute neutrophil count less than 200. So that is the your diagnostic criteria, and not the diagnostic criteria, that is the clinical significance, and that is the classification of your neutropenia. Now coming to one of the most commonly used risk stratification index. In risk stratification we can use is something called as multinational association for supportive care in cancer scoring, or otherwise we can call it as MASCC tool. So basically it will take certain weightage points like we do for any criteria, but only one difference is that as the score increases, if the score is above 21, they are of low risk, and as the score decreases, they are having high risk to develop neutropenic sepsis. So that is the basic difference from our routine scoring system. As it is above 21, the risk is low, and if it decreases below that, as the score comes down further down, the chance is high, the risk is high. So the common factors that they consider is burden of febrile neutropenia with no or mild symptoms, you will give a weightage of 5 points, and no hypotension, you again give a weightage of 5 points, and no COPD history, we again give a point of 4. Solid tumor or hematological malignancy with no previous fungal infection, again we give a score of 4. No dehydration requiring parenteral fluids, we give a scorage of 3. Burden of febrile neutropenia with moderate symptoms, we give a score of 3, and outpatient status again 3, age more than 62. So this is the weightage. So if it is above 21, the risk is low. So that is one criteria that we can use. There is another criteria that has been developed, but this has to be used with consulting with a consulting oncologist whoever is seeing the patient for the last few days. So this is otherwise called as clinical index of stable febrile neutropenia, and there has been evidences shown that both MASCC score and the clinical index of stable febrile neutropenia sepsis score can be used again for the patients with to diagnose for the neutropenic sepsis. So now coming to the management in detail. So management priority is here. So the first important thing is that you should always have a high index of suspicion. So whenever a patient who is receiving chemotherapeutic agent or who is under treatment for any oncology department in our hospital, you always should always have a high index of suspicion. Are we dealing with a patient with neutropenic sepsis? So if they have not done any blood investigation recently, or you think that it can be a possible neutropenic sepsis, we have a point of care CBC CRP machine available here. So we can straight away go ahead and do a CBC, complete blood count, and see what is a neutrophil, and simultaneously you can send a lab sample for an absolute neutrophil count where you can get the definitive value. So that is one thing we can the turnaround time for a point of care device is just 2 minutes. So we'll just get the result as early as possible. But few patients, they would have already taken the blood sample from outside, and they will be coming to us with, sir, we got the blood test done and the count is very low. So that is one group. So we always should have a high index of suspicion, and priority being an emergency physician is to stabilize the airway breathing circulation. So they can have if there is an associated pneumonia, there can be problem with A and B. So you need to sometimes need to start them on oxygen, NIV, very rarely need to intubate them, and they can have issue with circulation, as I told, hypotension. So generally, how will you manage the hypotension? As like any other patient, you start with unbalanced crystalloids, 20 ml per kg, 20 to 30 ml per kg bolus you can give over 3 hours and see how the patient is responding. The patient is not responding well, you can think of starting off one of the vasopressor agent. So again, the drug of choice is noradrenaline during that area. So generally we do for any sepsis, you have to take care here itself. So stabilizing the airway breathing circulation is the priority, and always keep in your mind the sepsis bundle. So sepsis bundle is what we do for all patients that is with suspected sepsis that is coming to the ED. So the sepsis bundle comprises of measuring the serum lactate level, so documenting the serum lactate level. If it is above 2, we'll call it as hyperlactemia. Above 4 with acidosis, we can call it as lactic acidosis. So we have to measure the serum lactate. The next thing, you need to draw the blood cultures, ideally aerobic and anaerobic, but at least aerobic you should draw, and start them on a broad spectrum antibiotic depending upon what organism you are suspecting. If you have nothing in your mind, you start with a broad spectrum antibiotic initially, like carbapenems to start off with, or piperacillin tazobactam, or cefepime tazobactam, or cefepime plain. You start off with any of these broad spectrum antibiotics, and again, if there is hypotension, you start them on IV fluids of 20 to 30 ml per kg, balanced crystalloid. These things you have to do within 3 hours as the patient is coming to the ED. So that is what we call it as a sepsis bundle, and later on we can remeasure the lactate and see whether there is a good lactate clearance, and we can see what is the blood pressure. If you need if it's a refractory shock, if you have already started the patient on one of the inotrope and still the patient is in hypotension, we call it as refractory shock, refractory septic shock. That is the time when you have to think of giving hydrocortisone 50 mg q6 hourly. So refractory septic shock, no need to send serum cortisol at that point of time. So refractory septic shock, once you give IV fluids, still there is hypotension, and you have started one of the vasopressor agent, still the hypotension is there, you start one of the steroid. That is, the recommended one is hydrocortisone or either fludrocortisone. So that is the sepsis bundle. Vasopressors, as I already mentioned, noradrenaline is the preferred choice. And the question arises is, shall I start in the peripheral line? Yes, you can initially start off with the peripheral line. Maybe within 1 or 2 hours you convert into an either EJV or put a center line and you start administering these drugs. So the problem in neutropenic sepsis, we don't want many indwelling catheter to be placed in these patients. So maybe you just give a good fluid hydration, just take care of their A, B, C, D, the initial phase itself, they giving a broad spectrum antibiotic and certain other therapy the patient will recover by themselves. And there is a general care that you have to give for every patient, and specifically here neutropenic care that needed to be given, and isolation, a single, preferably in a busy year, it is, I know it is difficulty, preferably a single staff should be assigned to that area, or you should be keeping these patients in a simple isolated area, but it is very difficult to get an isolation area in a busy ED. So basic neutropenic care, hand washing and all those care has to be taken care of, and rigorous oral hygiene, that is one another most important thing that you need to take care of. Oral antifungal agents, chlorhexidine mouthwash, and again these are all precautions that can be given for any patients that is we are having suspecting neutropenic sepsis. Most importantly, you have to start them on a broad spectrum antibiotic, preferably an anti-pseudomonal bar MRSA. That is a preferable agent. You can go with ceftazidime, piperacillin tazobactam, or a carbapenem group. So when you are suspecting MRSA, you can go with either vancomycin, linezolid, or daptomycin. These are the agents that will cover MRSA also. And when you have vancomycin resistant enterococci, linezolid and daptomycin is the choice. But in routine in an ED, when you have such a patient, you have to start on a broad spectrum anti-pseudomonal penicillin. That should be sufficient enough. Either of the anti-pseudomonal penicillin of carbapenem, you can straight away start off. Now, in low risk patients, so that we don't see in our ED, but some patients that they have missed their OPD and they will be coming to our ED. So, in low risk patients, they can be sent off with an oral antibiotic, preferably a quinolone, fluoroquinolone plus amoxicillin clavulandicating is the recommended outpatient management, and clindamycin can be given if there is a suspected penicillin allergy. And for high risk patients that we have categorized them with the MASC score, and you have found out that they are at high risk, definitely you need to start them on a broad spectrum antibiotic. So broad spectrum antibiotic of choice already we have mentioned, and also keep in mind the role of antifungals. So suppose you are suspecting an antifungal fungal infection, definitely you need to start on an antifungals also. That you can maybe leave it to the choice of the treating physician, whoever is been taking care of that patient for the last few days. So our aim as an ED physician is to recognize it first. You need to recognize that, okay, this is a neutropenic fever. So what are the things that you need to confirm your diagnosis of a neutropenic fever? So which all patients that you need to suspect, especially patient who is on hematological malignancy treatment. So you need to suspect them on chemotherapy. They are coming with sore throat, fever and all those things, neutropenic fever. Along with your checking your blood count, it is found to be low. As I told, ANC less than 500, you can call it as neutropenic fever. So our aim to stabilize airway breathing circulation, start them on an IV fluid, see if there is hypotension, balanced crystalloid is the fluid of choice, and draw blood culture and give them a broad spectrum antibiotic. So that will be the initial management, and later on, depending upon suspicion, you can add antifungals. So that is regarding a quick overview of neutropenic fever. Now we will go to the one of the other important thing is that granulocyte colony stimulating factor, whether to give or not. Yes, if it is a drug induced, it has got recommendation. Yes, you can give that, and usually you can give around 5 microgram per kilogram per day as a sub-Q injection. So we give it as a 300 microgram sub-Q stat. So that is the dose that we usually use. So if it is secondary to due to the drug that you have given, that is a chemotherapeutic agent that you have given and caused this, you can definitely go ahead with giving granulocyte colony stimulating factor. Now coming to the next one, that is tumor lysis syndrome. So tumor lysis syndrome is a rare but potentially deadly metabolic crisis with an estimated mortality of around 30 to 80%. So that is the estimated mortality, but with an early aggressive introduction, the mortality can be reduced. So we need to always have a high index of suspicion. So TLS is most frequently encountered metabolic complication of hematological malignancy. So it can occur as a part of the treatment, or it can occur spontaneously also. So the most commonly it occurs of following chemotherapy, but it can also happen spontaneously also. And patients with solid tumors are rarely develop TLS after chemotherapy. But you always remember that hematological malignancy patients are very frequently develop this tumor lysis syndrome. And also you remember that those who are already having a baseline renal dysfunction and with comorbidities, they have high risk of developing tumor lysis syndrome. They are taking multiple medications that can cause increase the potassium, that can cause renal failure. They are at high risk of developing this tumor lysis syndrome. And presenting symptoms, again, it is not specific. It can be any of this, including your generalized fatigue or signs of dehydration. They can come with seizure, cardiac arrhythmias, nausea, vomiting. So the presentation can vary. So it all depends upon what electrolyte disturbance they have underlying, and the presentation will be depending upon that. So we will not be able to predict, but again, when you should always have a high index of suspicion. Suppose a patient is coming to you with generalized weakness and you do a blood gas immediately and you are finding out that there is severe metabolic acidosis. Also in our ED we have got a facility to get the creatinine value also. You are seeing the creatinine is very high, the potassium is elevated. So all these things you should have a high index of suspicion, or I am dealing with a case of tumor lysis syndrome. So again, we have got a good diagnostic criteria for that. So that is the Cairo-Bishop criteria for clinical and laboratory tumor lysis syndrome. So 2 or more of the following criteria, either 3 days prior to or 7 days after chemotherapy, you have a uric acid above 8 mg per deciliter or 25% increase from the baseline. So that is one important thing. Or serum potassium of more than 6 milliequivalents or 25% increase from the baseline. Phosphorus more than 6.5 mg per deciliter for children and 4.5 mg per deciliter for adults, or again 25% increase from the baseline. And calcium, you will see hypocalcemia here, less than 7 mg per deciliter or 25% decrease from the baseline. So these are the lab criteria by which you can say, okay, you are going to deal 2 or more of these things are there, you can suspect a tumor lysis syndrome. And clinically, when you say tumor lysis syndrome, laboratory tumor lysis syndrome plus 1 or more the following: creatinine more than 1.5 times the upper limit of age adjusted reference range. So we have to have the calculate the age adjusted creatinine, and you need to find if it is more than 1.5 times they are again, that is one of the clinical criteria. And cardiac dysrhythmia or sudden death or seizure. So this is how you need to have a high index of suspicion that, okay, am I dealing with a patient, you are seeing a high routinely we don't do uric acid. So you have to always, whenever you have a high index of suspicion, the patient was on some hematological malignancy, so he is undergoing some treatment, or he can come with spontaneous tumor lysis also, you need to have a high index of suspicion. So this is the Cairo-Bishop criteria. Now coming to the management, once the TLS is identified, the initial intervention consists of aggressive fluid resuscitation. So IV fluid is the mainstay, and you need to correct the electrolyte disturbances. So maybe 2000 to 3000 liter meter square per day. We need to have you need to have a good urine output, around 1 to 2 ml per kg of urine output you need to maintain. That is around 200 ml of urinary output you need to maintain. Then only these electrolytes will get corrected. So that is one important thing. So fluid resuscitation is the key. And hyperkalemia, just like any other hyperkalemia management you need to do, if required calcium gluconate, if required GI bolus, you required Lasix, furosemide, potassium binders, even dialysis, you need to think all those things if when you are suspecting. But ultimately the dialysis may be required for severe refractory tumor lysis syndrome. So that is one important thing. So renal failure as well as severely elevated uric acid, potassium or phosphate level, definitely that patient require dialysis. Also phosphate binders can be used, aluminum hydroxide 300 to 600 milligram oral dose can also be tried if the serum phosphate level is very high, that is above 6. So again, the patient can have significantly symptomatic hypocalcemia. You might need to treat them. Either they can have seizure or cardiac toxicity with IV calcium gluconate. So coming to quickly view of hyperuricemia management, allopurinol is a xanthine oxidase inhibitor. That is one agent that we can give. It is administered to reduce the conversion of nucleic acid byproduct to its uric acid. So again, you can try allopurinol. So administration of allopurinol is recommended for prophylaxis in patient with low and intermediate risk of developing tumor lysis syndrome, and it is usually given at a dose of 600 milligram per day and once a day prophylaxis. That is the prophylactic dose. But alternatively also you can use febuxostat, which also been found to be effective. So again, the dose of febuxostat here is very high. So general therapy will give 40 mg, but here you need to give 120 milligram of febuxostat. So that is the one management of hyperuricemia. And there is another drug that is called as Rasburicase. which is again indicated when you have an hyperuricemia associated with malignancy. You can use Rasburicase. You have to give it as an IV 0.05 to 0.2 milligram per kilogram once daily for 1 to 7 days. So average of 2 to 3 days you need to give. It is the duration of the treatment depending upon the plasma uric level. If the level is very high, like 15, 20, 30. We had a patient a couple of months back with a uric acid level of above 25. So again, one of the indication to use is very high level of uric acid. You can give Rasburicase, and it has got a unique mechanism of action that allows uric acid byproduct to be easily excreted by urine. So that is in a nutshell. So tumor lysis, our primary aim is to identify. You should have a high index of suspicion. Okay, am I dealing with a patient with tumor lysis syndrome? I am seeing hyperkalemia. I am seeing some renal failure. It might not be just due to the acute kidney injury, or whether I am seeing high phosphorus. I am also seeing low calcium. Whether it is a tumor lysis syndrome, you go back and review back the patient. It can be a tumor lysis syndrome. So always have a high index of suspicion. That is a priority number one to treat, and the treatment is pretty straightforward. The priority might be to start dialysis as early as possible, treat the hyperkalemia, treat the hypocalcemia, treat the hyperuricemia and hyperphosphatemia. So to conclude, so primary role for an emergency physician for us is to stabilize the airway breathing circulation. So without high index of suspicion, we will never come to a conclusion that it is a neutropenic fever or it's a tumor lysis syndrome. So always we should have a high index of suspicion when these group of patients are presenting to our ED. So as I told, any of the oncological emergencies can be due to one of the metabolic problem, or it can be a hematological issue, or it can be structural or a treatment related, which what we commonly see. So treatment related is what we frequently see. The neutropenic fever is secondary to the chemotherapeutic agent. As I always say in the presentation, early recognition and management holds the key for the management of oncological emergency. So due to the lack of time, I will just stick to the management of two. Thank you for your listening. Thank you.